Robert,
Hi.
while people are coming on, this is my third time doing one of these Instagram lives, and I found that we wait a little bit for people to come join. I see Jen Shannon joined again. She was here yesterday during our test run. Good to see you.
Fun test run.
Yeah. So Robert, tell me a little bit about yourself. Like, how'd you end up doing what you're doing right now while we're waiting for people to come on board before we get started?
Yeah, so I studied healthcare management policy at Georgetown, and I kind of got caught up in the idea that we could potentially deliver healthcare services through mobile phones at one point. And when I was 20, I lost my mom to leukemia.
Oh,
And so through that whole caregiving experience, I was like, there's so many things that we could do better just like through the phone. And there could be data collected, there could be there could be communication that's better. Patients don't have to drive to the clinic. And so I was like, why would we not do that? So I ended up writing my thesis on value-based payment and Medicaid. And one of the things that came out of it was, well, we still have these problems with how we actually deliver services to patients. Like, we can change the payment methodology, but if we can't do anything to like actually affect change, then at the clinical level, then you won't meet the demands and the goals of those programs. And so I was like, well, we need to figure out some way that we can solve some of this. So I got interested in this space and virtual care and telehealth.
wow. Well, I'm so sorry to hear about what happened with your mom. It's just that's awful.
Yeah.
And I can see how you have the passion that you do with technology and really introducing technology into healthcare, and we should probably get started. I think now would be a good time to get started. Do you think it's okay?
Yeah, I think that'd be good. But you have to share with us how you, as a physician, got interested in value-based payment first.
Yeah. My background, I went to medical school in the Dominican Republic, and after residency, actually I did residency at an unopposed family medicine program in Columbus, Georgia. And after completing residency, I joined a community health center in Tampa. We had a large number of patients who were unfunded, patients who were underinsured, meaning they couldn't afford their copays and deductibles. And I've always been driven to make sure that everyone gets treated the same. Everyone should have access to medical care, regardless of their ability to pay. And I remember it bothered me so much how many people delay care because they don't have access to it.
Yeah.
And because of it being so complicated and difficult. And it was while I was doing my community health work that I got introduced to ChenMed. Actually, I met them I remember walking past their booth at a conference, and I asked the person working at the booth about, well, what's ChenMed? I never heard of ChenMed, and she said, oh, we're this geriatric organization providing like this first class level care for seniors and all that. And I said, oh, it sounds wonderful, but what happens to the people who don't have insurance? And she said, we only see people who have insurance. And I said, oh, you're just another money-making place. And I actually walked away from her, and she came running behind me saying, Dr. Sayed, it's the same patient panel that you're looking after, except they all have Medicare. They all are Social Security. So they're all on fixed incomes. This is the same patient population you're dealing with, except we deal with the elderly.
Yeah.
And that's how the conversation started. And then before I knew it, within a couple months, I was I found myself at ChenMed, and this is my fifth job at ChenMed now. So a lot of growth in the organization.
Yeah. I've seen the company pretty much grow up pretty fast under the value-based care revolution. But let's do this virtual care thing.
Yeah. So, Robert, if you can tell me, what is virtual care?
Yeah. Well, it's what we're doing right now. I think that the best way to describe it is being able to provide healthcare services over the phone through video chat mechanisms. And there's a whole bunch of different types of value-based care, which or not value-based, virtual care, the V words. And we'll jump into those a little bit more later on in the chat, but it's truly providing healthcare services that are more convenient and effective for patients that are in the home or in other locations, so that healthcare can follow people wherever they go.
Well, why are we talking about virtual care like this in 2020? I mean, we're 20 years into the 21st century. Why are we talking about it like it's?
I have this come up at work all the time, where I'm like, guys, this isn't that far of a stretch. I was like, we do everything else digitally. We got rid of Blockbuster and going in person to get movies a while ago. And so it's like, why? It's not really a novel concept. It's just taken a long time to get to this point. And, I struggle to answer that question, but, I mean, what do you think? Why did it take so long to get here?
I mean, definitely virtual care is top of mind right now. It is like the in thing. It is the exciting thing that we're kind of, with COVID, we're being forced to explore. And I think that's which probably has to do with the system itself not being incentivized to provide a way to make care more efficient. Now, I think about my father being an inventor. And my father was an inventor at AT&T Bell Labs, which was considered the think tank for the country. And he has a bunch of technical patents with caller ID, voice recognition, DSP technology, I mean, bunches of flash memory. But it would take 30 years, up to 30 years for many of those patents to really see the impact of the patent. And it was because the system wasn't incentivized to release a lot of that information right away. So, for example, like with voice recognition, they had functional voice recognition back in 1984. Why did it take more than 30 years for like Siri and stuff like this to come out like that? And it's because the system incentivized releasing it slowly in bits and pieces so that, the stock market and whatever else is there could benefit. It wasn't so that society as a whole could just benefit immediately. And I sort of think with virtual care, it's sort of along those same lines too. Prior to COVID, half of all medical care was delivered in the emergency room setting.
Yeah.
So that shows that obviously the care in our system wasn't being delivered efficiently. The care in the system has been inefficient. So now, because of COVID, we're being forced to look at things differently.
Well, I mean, part of that issue with the 50% of healthcare being delivered in the emergency room is that emergency rooms are super expensive, and they lead to people getting like perhaps some inpatient services that are high value for facilities, but may not actually be necessary for the patient. When the same services or better quality services can be provided in like a primary care setting or even perhaps virtually, as opposed to having to go to that extremely expensive place. So it costs the country a whole bunch of money, and it's probably not the best way for patients to get care. I mean, they have to wait in line in the emergency department for a long time if they're not high acuity. And, why not do it this way? It's faster, it's more convenient, and it's better. But, there's a whole bunch of different iterations of virtual care that are out there.
Yeah. Why don't you go into that? I mean, virtual care means so many different things for different people.
Yeah. So, I should say it's a relatively new space. So virtual care kind of covers all types of healthcare services delivered through a digital medium typically. And I like to break them down into sort of two categories. One is better communication that's facilitated through video chat and video conferencing like what we're doing right now. And then one of them is sort of connected data collection from patients through wearables and mobile device. So that typically falls under the category of like remote patient monitoring and connected care models. And so those types of things collect blood glucose in real time from patients and blood pressure in real time from patients. And so that works in conjunction with things like telehealth or telemedicine or just general virtual care that might describe more of the communication that we're having with the healthcare professionals. So you can imagine that there's a whole bunch of different iterations and models that can be built when you're able to collect data from patients in real time from the home and, actually have people have conversations with the healthcare provider through this type of medium. And so it's super exciting thinking about this going forward and working in this space where it's like we've opened up a whole new world of possibilities for how we can deliver healthcare services in the country. And, we're all very stuck in this old model of we go to the doctor when we're sick. And now we're trying to move things to be more effective and more proactive and reflect more of the patient experience.
Yeah, I think it goes back to the system.
Yeah.
95% of healthcare in America is still fee for service, meaning that it's a transactional sort of system, a billing system. So the system is incentivized for managing more complicated situations, waiting for a problem and fixing that problem waiting for it to become an emergency situation or a hospital situation. I think that's probably part of the reason why you have 800,000 specialists and only 200,000 primary care doctors.
Yeah.
Because the system incentivizes that.
Yeah, I mean, I think it was you who told me one time that the system does exactly what it was built to do.
Yeah,
And I love that because, in my book, I kind of talked about this intersection between how we pay for healthcare and how we're trying to use technology to improve it. And I have a chapter about the history of it. And the healthcare system, as we know it today, really formed out of this idea of like accidents that might occur. And so the way we built coverage, the way we built our healthcare system was for low frequency events that were serious and people needed catastrophic coverage for it. So these were the first insurance policies. They're called accident policies. And so we didn't really have a lot of tools back in the early 1900s when these were built to actually help patients with more sort of long-term conditions like chronic illness. And so we built these policies and kind of kept the system the same as it evolved. So we're now moving into something where we can try and do things a little bit more real time and be more proactive with healthcare because technology and medical science have really progressed since then.
You're talking like 2020 solutions for 2020 world.
Yeah.
Where I feel like everyone else is like talking about when they're still talking about faxing medical records, or when they're talking about using 1970s technologies to solve 2020. I mean, I'm in the middle of a home renovation right now. I don't know if I told you we just bought a house. It's a fixer-upper, and one of the most exciting things with the home renovation we're doing is making it a smart home. So I have like getting the automatic lawnmower robot to like mow the entire yard and being able to talk most commands like anywhere in any room and just all the convenience of all of that. That is for 2020, right? To go back to living like from the previous century is just so ridiculous to me. And in my world, obviously I do geriatrics with elder care. I think about like my father is one of our patients. He's almost 70 years old. And he's been waiting. He said he's been waiting for decades to be able to have this type of experience. Yeah. Where, I mean, even with just using FaceTime or anything like that, that type of communication for someone like my dad, he's really only doing it with like me, my brothers, our kids, maybe some family members. But who else better than his primary care doctor to have that kind of relationship with? Yeah. You don't have to spend like half a day to go to the clinic and sit in a waiting room and deal with all of that. Yeah. I mean, he's literally in his at his kitchen table with like a t-shirt on and just very comfortable and relaxed. He loves it. I mean, he's never been closer to his primary care doctor because of having this video connectedness with him. Yeah, I think that brings up a really interesting question, interesting point. And one thing that I did the other day was I kind of introduced what I do at work at a virtual care company to my grandma. Oh. And I was like, hey, this is how it works. This is what I do. She's like, oh, you mean like I don't have to go in to the clinic? And I'm like, yeah, you don't have to take 40 minutes to drive there. I was like, you can do some things, through a mobile device or through your tablet. She has an iPad. But one of the questions that I get so frequently at work is, can older patients use this? Like, do they want to, and are they able to actually access these technologies? And they do. I mean, this is like the George Jetson generation. They've been waiting for this. I mean, that's like my dad said. I mean, he's been waiting to be able to have technology and the ease and the convenience of technology. Yeah. And we're finally at that point now. And I think that's one of the things that we're seeing with COVID is now all, the payments are starting to be matched up. And I think that'd be a nice thing to talk about next time. How are we going to pay for it? Yeah. I mean, I think that's one of the big questions is like, why would I want to do this as a physician or as a healthcare organization or, who does pay for these types of services? So I think, next time we hop on the call, that's what we should do. Ah, great. Well, this was a lot of fun. Didn't know that we could do that. I could have two people like this on Instagram Live. Yeah, I didn't either. We're not in the same building, everybody who's watching. We're far away. I know you're in DC, I'm in Tampa. Yeah. This is crazy. Great. Well, till next time. Yep. All right. Take care. Yep. See ya. Bye.